Thank you, Sharon, and thank you, everybody. I have a bit of a cold, so if I sound hoarse, I apologize. All right. So I'm going to be talking about pediatric tuberculosis update. I modified the title of my presentation to make it a bit broader than just the perspective from Haiti, but I'll sprinkle in the LMIC perspective, certainly. I don't have any conflicts to disclose. This is going to be the outline of my talk. And since I'm the only person talking about tuberculosis for this meeting, I'll make sure to cover a little bit for everybody so you all remember that TB is still important. I'll start with a thought-provoking, maybe, question. We've been talking about ending HIV, but can I ask you, do we think we can end HIV without ending TB? So let's start with a little bit of where we are today in terms of epidemiology. The WHO 2021 Global TB Report lists that in the middle of the pandemic, so 2020, about 10 million people developed tuberculosis. Of those 10 million people, 1.5 million died. That's just 1 year. Of those, about 1.1 million were children, 0 to 15, and that 1.1 million with active disease is from an estimate of 7.5 million, just children now, who are infected each year with tuberculosis. The 1.1 million children with active disease, the biggest burden is really spread between the children less than 5 years of age, with 47% of the little people having active TB, and the rest being adolescents, about 727,000 adolescents having active TB disease. So it's a lot of tuberculosis for a lot of little people in the world. And unfortunately, still a lot of mortality in our children. So 226,000 children died of TB. And once again, the less than 5 carry the greatest burden, with 80% of them dying. And it's astonishing that it's estimated that 96% of children who died with tuberculosis did not have access to either TB diagnosis or TB treatment. So we're clearly missing the mark. And there's a lot that needs to be done. Our children who are living with HIV are also greatly affected by this. And there were about 21,000 children with HIV who died of tuberculosis, as we remember, which is a totally treatable and preventable disease. So if we focus on the global burden of TB in children less than 15, they represent about 12% of the global burden, which is a lot, but not a lot. And that's historically one of the reasons why they haven't been prioritized. But there's been good estimates of data, and it ranges from 1 million to 1.1 million active TB disease cases. On the left-hand side, you can see that really there's a really small group of countries that really share that greatest burden, with India, Pakistan, China, and Nigeria having the greatest absolute numbers of active TB and TB infection cases. But then everywhere around the world, there's tuberculosis. I come from a very small country of 11 million people, but our TB prevalence rate is very high. It's highest in the Americas, with close to 200 cases per 100,000 population. So in terms of absolute numbers, it's not very high, but it represents a big burden, and a lot of work needs to be done. The greatest burden of tuberculosis remains drug-susceptible TB, and the diagnosis is still as challenging as before. And the mortality we've talked about, and the excess mortality with HIV. And as a reminder, TB is number 13 killer, all ages confounded, and children less than 5 is one of the top 10 killers of children less than 5. So how has COVID impacted tuberculosis? I think this slide is very obvious, terribly. There was a significant decrease in TB notification rates from 7.1 million in 2019 to 5.8 million in 2020. That's huge. That's an 18% drop. And In children, the TB notification rates obviously have been impacted, with the greatest impact that you see in, once again, the 0 to 5 with a 28% decrease. We were already missing them. Now we don't even know they're dying of TB. And for the first time since 2005, our TB deaths, which had been decreasing, increased in 2020. This is a very sad milestone that with the COVID pandemic, we really lost a lot of the gains we had gotten. So the HIV uninfected population, there was 1.5 million people who died, up from 1.4 million, and the HIV infected, that's 214,000, which is a smaller increase. So TB really affected mortality in the HIV uninfected. This is what this slide shows, really, that there were double TB deaths compared to HIV/AIDS death. And when you think that TB's been around much longer than HIV, it really underscores the differentiated work and effort that we've done, the funding, the policy, the research that has been poured into HIV compared to tuberculosis, that in 2020, more people are dying of tuberculosis than they're dying of HIV/AIDS. With COVID, there was a lot of delayed presentation, which meant that the little people presented very, very sick. That's the ones who didn't die. That's just a little guy at the clinic with just very extensive ganglionic TB. And as a reminder, oops, sorry about that. The COVID pandemic really exacerbated the health access disparities. So the people who had already limited access to healthcare were the ones who were the most affected. And delayed presentation also meant very severe disease with children presenting. We had a little 3-year-old who presented with basically paralyzed. He couldn't walk because he had Pott's disease, and he'd had Pott's disease for 8 months. And it's remarkable that we're still seeing this in 2022. So very extensive disease. You're seeing chest x-rays that look like they belong to adults, but this is pediatric chest x-rays. And obviously children presenting with severe acute malnutrition as well. This should not be pictures from 2022. So as we all know, COVID impact on health services obviously led to delayed health-seeking behavior. People were afraid of going to the hospital for fear of getting COVID. There were obviously lockdown and restricted local travel with the messaging of staying home. And there was a decreased focus on preventative and other treatment services. So the health services were overburdened. There was a lot of stigma, in particular with TB, any respiratory disease. In many countries, people were afraid of seeking care because they would be afraid to have COVID symptoms. There was a fear of collecting respiratory samples as well. And of course, we all know that our laboratory systems were completely overburdened. And paradoxically, one of the main platforms that was used for PCR COVID testing, the SafeFeed platform, was the TB platform. And because of supply chain issues, we just took the SafeFeed machines, put them in use for COVID, and just forgot about TB testing. So that severely limited. It explains in big part the decreased case notification rates. And obviously, everything was closed, so there was no access to child health services. Even pediatric wards were turned into COVID wards, and then there was reduced staffing, as you all know. So I think this slide from the WHO really sums it up, that the COVID-19 pandemic reversed years of progress that had been made in the fight to end TB. And for the first time since 2005, we have increased TB deaths. There's fewer people who've been diagnosed and people who've been treated, and fewer resources. As we know, all the money was diverted to addressing the COVID pandemic. But we do need now to have important actions to mitigate and even reverse the impact of the COVID pandemic for promoting access to essential TB services. So where are we in terms of TB diagnosis? Are we diagnosing TB, or are we still missing TB? I think this slide from the 2021 WHO report shows that we haven't made much progress. It's pretty much a flat line across many of the WHO regions. And while it looks like it's a decent number, 59% of reported TB cases are bacteriologically confirmed, that number is less than 15% for children and adolescents. So we're really missing the mark. And while we have new tools like the GeneXpert, the SafeFeed machines that are rapid diagnostic tests that provide, that are really revolutionary and provide an answer in 90 minutes, the scale up of these wonderful tools really are very slow. 21 of the 49 high-burden TB countries are using them as first-line tests for greater than 50% of their cases. So we have the technology, but we really need to work with countries to use them so that they can reach the patient populations. We need funding to support the TB programs and really improve the use of the NAT testing. As you all know, diagnosing pediatric TB is extremely difficult because it's very paucibacillary in nature. Children often present with nonspecific clinical signs and symptoms, particularly the very young. And they can progress to active disease from infection very quickly without even presenting a lot of symptoms. And there's a high mortality in the young, especially if they have HIV co-infection, severe malnutrition, or severe forms of TB, such as miliary TB and meningitis. So as it remains difficult, what are we going to do about it? There is some good news. It's not at the point of care yet, but there's some innovative partnerships that are being done. There's computer-aided detection tools that have been developed to assist in the interpretation of chest X-rays. It's currently validated for children 15 years and above and adults. And there's work being done for building a library of images for children less than 15. And that is very important because triaging is really one of the first steps of identifying children with TB. And internationally, it's very difficult. Of the places that have access to chest X-ray, it's really important to be able to understand, is that chest X-ray abnormal? Should I proceed on to further testing? The WHO has endorsed use of CRP testing as an inflammatory marker as well. There's some pretty cool artificial intelligence technology that is being developed. One of them is the cough app. It actually helps distinguish. I don't know how it works, but apparently it helps you distinguish different types of cough, just to really show that we really need to be thinking outside of the box. If this has been around for that long and we still can't figure it out, maybe it's going to be one of our teenagers with their smartphones and with their, artificial intelligence technology that's going to help us do it. There's also been the promotion of new testing platforms. The GeneXpert SafeFeed platform has been great, but there's been really a monopoly on the field and lack of newer platforms. So WHO recently validated and approved the TrueNat as well. Now it needs to be scaled up and purchased and delivered. And we need to leverage, as was been said for the HIV epidemic, we need to learn from what we did for COVID. There was a tremendous, in the 2 years that we've been dealing with this disease, we've done so much. Can we learn from that? Can we use non-sputum-based testing? This is particularly important for children that can't cough and spit in a cup. Tongue swabs have been evaluated. Self-testing, home testing, we really need to look at this. We thought it couldn't be done, but then COVID taught us that this is definitely possible. And we need to scale up point-of-care rapid molecular tests, lateral flow rapid antigen tests with TB biomarker profiles. I think there's a lot of hope for what can be done to improve TB diagnostics. The Treatment Action Group has this wonderful pipeline report that they published that really summarizes all of that. Some of the new innovations as well are improving the urine LAM test. The current one that is being used has very low sensitivity, but it's a very easy test to be done. There's a new one from Fujifilm that's better. It's still expensive, so they're working on getting it on the GGG purchasing platform to make it more accessible. And then we need to move away from very archaic methods that are still being used around the world, like smear microscopy to diagnose TB. So the WHO has endorsed that we should be using molecular diagnostic that has improved sensitivity, and you get a 2-for-1. You get to know, is this TB and is it drug susceptible or drug resistant TB in one test. There are challenges that need to be addressed. It does require laboratory infrastructure, such as you need an office, you need electricity to plug in the computer, and the cartridges are still $10 a pop, which is definitely more expensive than doing a Zeal-Nielsen test. And we need to have increased drug susceptibility testing, which is coming. The gene expert platforms are going to have more than rifampin resistance as well. They're going to be looking at fluoroquinolones as well and other in INH. Just as a reminder why it's important that we don't miss the little ones, I'll just give you a little vignette. We had a little 18-month-old who was seen with an aunt. This is very typical. You know, the mother is absent for whatever reason. You don't get a very good story. The kid was failing to thrive, was somewhat less playful. But then there was a lot of other reasons why things weren't going well at home. There were some migration issues. The kid looked stable, didn't have a fever, didn't have a cough. When you ask, they don't know about any TB in the house or in the neighborhood. You do your workup, you manage to get a gastric aspirate, the gene expert on it is negative. Your chest x-ray looks like this. You're not really impressed. You give antibiotics, you refer for nutritional rehab for moderate malnutrition, and then the kid has lost a follow-up. You see the kid back 8 months later in severe respiratory distress, and the baby has miliary TB and dies a week later. And oh, by the way, the dad was diagnosed 2 months earlier with pulmonary TB. So clearly, it's hard. It's hard to diagnose TB in children, and when it's obvious, it's obviously too late. So we need to improve how we're doing this. So as I said, WHO endorsed using molecular instead of microscopy, and also broadening specimens. Doing a gastric aspirate requires a lot of infrastructure, a lot of trained personnel, and basically just makes it impossible to be done in rural settings or more limited settings. So stool is being looked at, but we do need better diagnostic techniques as well. So what can we do to improve this case detection gap? As you can see, 72% of children less than 5 estimated to have TB are not even being picked up. And of those who are exposed to TB, almost 2/3 of the 1.1 million eligible contacts less than 5 were not even offered TB preventative therapy. So what can we do to improve this? So we do have drugs that work. There is a nice little table with a bunch of different options. Some work, some have other problems. So historically, INH prophylaxis for 6 or 9 months, it's the cheapest. However, the uptake is really poor. Healthcare providers don't offer it, or families don't complete it. 3HP is really a really wonderful option that's come around. However, its dosing has been validated for 12 years and above, and recently for 2 years and above, but there's still no child-friendly formulations, while Sharon is desperately working to fix that. Right, Sharon? It's important that when we think about the research, we work with our partners at industry as well, because we have the drugs, but they're not interested in making the drugs for the children. So we still have that problem. So we need to be thinking as well, we don't need to be treating them when they have active disease, because it's hard to identify active disease. We need to be moving at treatment of TB infection. It's the equivalent of treating people when they had CD4s less than 200, right? Back in the days when we withheld treatment to people who had HIV until they were like death and dying, I think TB is the equivalent. We should be treating TB infection and not waiting for people to have chest x-rays that are impossible. But if you look at the global number of people who were provided TB preventative therapy, obviously is that a pointer here?
Sound good.
29% of our targets were offered TB preventative therapy. The target for children is 6 million children should be provided TB treatment, and we're doing not a very good job. And it's important, we have the drugs, so there might be some limitations, but INH has been around forever, and we know INH works. So we need to be looking at behavioral studies that help us reach those children that are at risk, those adolescents. We need to have novel ways to initiate TB treatment infection, and we need studies to help engage families on how to complete TB treatment. Just like HPTN 052 taught us, right? It only works if you take it. And, sorry, I moved back. It's the same thing with COVID vaccines. We have wonderful technology, we have wonderful new drugs, but then if our target audience is not interested, then we're missing the mark. TPT scale-up internationally has been extremely slow. From clinical trials to guidelines to national implementation, the delays are in years. And this table just reminds us of the important steps at the policy level, planning level, implementation, preparation, training, early implementation, and the monitoring that is required. So if we need to end TB and if we need to be saving 1.1 million children per year, we really need to get going on this. What's new for treatment? Unfortunately, just like for ART, even worse, treatment coverage has been extremely low. Pediatric treatment coverage in 2020 was 41% for drug-susceptible TB and 11% for drug-resistant TB. So clearly a lot of work to be done there. And as a reminder, I thought this slide was wonderful from the Global TB Report. It's a reminder that TB is still the disease of poverty. That when we're doing all these clinical trials that look at the different medications, the biomarker profiles, the reason why our patients are getting TB is that we have health equity and basic access to food issues. In a lot of those countries that are impacted as well, there's a lot of violence and a lot of political disturbance. If you look at the bottom right, cases attributable to 5 risk factors, malnutrition wins the race. It's really impressive compared to HIV. We do all this work for HIV, but we forget that our patients are just dying of hunger. WHO has come up with updated treatment guidelines. They're great. There are different modules. I encourage you to go look at them. 2 key things for pediatrics is that we've endorsed shorter treatment for non-severe TB. Children and adolescents between 3 months and 16 years of age can be treated with a 4-month basic HRZE regimen. And we've generated data through P1108 to use of bedaquiline and denamenid in children with drug-resistant TB. And this is wonderful. We've made so much progress for drug-resistant TB that we have moved away from the horrific injection, including regimens of years past. So this is the trial, the SHINE trial that generated the data for supporting the 4-month shorter treatment regimens for children with non-severe disease. Basically, over 1,200 children were randomized in India, South Africa, Uganda, and Zambia. They had non-severe smear-negative pulmonary disease, and it was a non-inferiority trial. And in per protocol, intention to treat and secondary outcome analysis,
it was supportive of non-inferiority. P1108, which is an impact trial, generated data for the PK safety of bedaquiline in children with drug-resistant TB, and WHO used that data to update their recommendation. And just as a reminder, bedaquiline was first recommended in 2013 for adults, so that's almost 10 years later for children. We've done progress for better regimens with DRTB in children and adolescents. We are using injectable sparing shorter regimens, less toxic drugs such as dilamidid, bedaquiline, clofazimine, and linezolid. But we do need to work on more child-friendly formulations in the pipelines and obviously address the social issues that are huge, particularly for children with tuberculosis. This is a nice snapshot. After 60 years of no new drugs for tuberculosis, this is looking busy, so that's wonderful. And there's a lot of research gaps. As I said, we need better tools for enhancing TB diagnosis in children. They need to be point of care, non-sputum based. We need to have biomarker profiles that help us distinguish TB infection versus TB disease. We can look at technology for helping us interpret chest x-rays. We need to improve case detection, because if we don't go to them, they're not necessarily going to come to us and we're not going to know. We need to improve reporting and treatment coverage, work with our industry partners to develop in a timely fashion child-friendly formulations, and we need to do the trials to get the dosing safety and tolerability, not only in children, but also in our pregnant women, because often the peripartum period is an often time of either the mother getting it and giving it to the baby. This is just a quick snapshot of the impact trials that are looking at the different TB studies, looking at MDR prophylaxis, and then different dosing and PK studies. So I'll end with the same questions I started with. Can we end HIV without ending TB? I hope I convinced you that TB remains an important public health emergency and we need urgent actions to address it. We need to use our lessons from COVID, re-engage the political commitment and the funding that was diverted, engage our community, and promote the inclusion of children and pregnant women in clinical trials. I skipped on the acknowledgement slide and I went back, but impact, the people at work, and obviously the families that allow us to do this work. Thank you.
Thank you very much. I think we have time for perhaps one question. Over there, at number 1.
Thank you so much for your talk. I'm Nadia Samagudu from the Institute of Human Virology in Nigeria and University of Maryland. You did discuss about TB prevention with respect to using drugs and so forth. But I also want to ask if you have any update or any information on TB prevention in terms of vaccines. You know, the vaccine we have is over 100 years old, BCG, and what's going on? That's all I want to know. Thank you.
That's an awesome question, but we're in line with everything TB. We're doing it century style. You know, everything takes us 100 years. But yes, I didn't have time to cover it. We're finally looking at TB vaccines, and we're looking at TB vaccines in 2 ways: to prevent infection or to prevent disease. And Impact Network, we have a couple of trials looking at infants or adolescents, and there's the adolescent trial is almost ready to go. But you're absolutely right. BCG is 100 years old, and we need to be thinking outside the box. We got a COVID vaccine in less than 12 months. Isn't that remarkable?
All right.
When there's a will, there's a way.
Thank you very much, Vanessa.